My name is Dr. Michael Bohan. I'm with Carolina Orthopedic Specialists, and I do primarily hip and knee replacement surgery. We have an office in Azalea Lakes in Myrtle Beach, and soon to be building an office down here in Murrells Inlet. Today I'm going to talk about a newer type of hip replacement called anterior approach hip arthroplasty, which is a fancy word for a hip replacement through the front rather than through the back. Our hip joints are actually right in the groin. If you feel your groin, that's actually where your hip joint is. So chances are, if you have a bad hip, a lot of your pain is going to be on the front or the side of the hip. Most pain that's from the back or the buttock is usually related to the spine. So that's an important distinction. People think the hip is this whole area, which it is in general terms, but in anatomic terms, that's not the hip. So our hip joint is a ball and a socket, a simple ball and socket, and there's cartilage. That cartilage is the cushioning between the ball and the socket. And if you can see these pictures here, this is a good hip here where we have the white cartilage. Over here on the left, you can see that all that cartilage is worn out. And just like any joint that's worn out, you get what's called bone-on-bone pain. When two bony surfaces rub together, that's extremely painful. So the symptoms of a bad hip usually are groin pain or pain on the side when you're sitting for a while and go to get up. That's kind of the hallmark of a bad hip. It's usually not running down your leg with numbness or tingling or pain in the back. It's pain in the groin when you go to get up, what we call startup type pain, getting started. A lot of people, when they get started and get moving, a lot of their pain is better as they get going. Today's talk is about surgery. So the most common operation performed for a bad hip or an arthritic hip is what we call a total hip replacement, which means we replace the ball and the socket. So the slide on the left shows a bad hip. There's no space between the ball and the socket. And this is the new hip on the right slide, where there's a new socket, a new ball, and a stem that goes down into your bone to anchor that whole construct. So that's what your hip looks like before and after. So hip replacement surgery is extremely successful. It's been around for 30 or 40 years. It's 90 to 95% satisfaction. Most people do better after a hip replacement than a knee replacement. The success rate of a knee replacement is a little bit lower than a hip. There's a little more therapy. There's a little more pain that goes along with a knee replacement. So a lot of people after a hip replacement can get back to normal activity and really forget that they had a hip replacement. The thing that I want to talk about today are the surgical ways that we get into the hip and replace the hip. Traditionally, these have been through the back, what's called the posterior approach, or the anterior lateral approach, which is more on the side. I'm going to talk to you today about a true approach through the front of the hip, where we cut no muscles, it's minimally invasive, and I'll go over the benefits of why we would want to do that. So this is traditionally a hip replacement. You lay on your side, the incision is on the side, but we get into the hip through the back, what's called a posterior approach. And it's been around for a long time, and it's worked very well. So you may say, well, what's the talk about? Why would we want to change something that works so well? Well, the problem with the posterior approach is that you cut through the abductor muscles, which are the muscles that help you walk, so that those muscles are repaired, but they're going to be weak for a period of time after surgery. So it makes sense to me, and probably to you, that if you can get by without cutting muscle, you're probably better off. You don't have to wait for it to heal, and if it's not cut in the first place, it's probably going to do better than a muscle that has to heal. So that's a big advantage to this. The other advantage is through the back, hips are more likely to have what's called a dislocation, meaning that the ball pops out of the socket. You may have had some friends that have had a hip replacement before, and they say they're not allowed to bend over, they're not allowed to sit in a low chair, they're not allowed to cross their legs. With this approach through the front, it's extremely stable. We're not detaching any of the muscles, so the risk of it popping out is extremely low. So dislocation, if you've ever known anybody who's had a dislocation, it's a very bad problem. So it's one you want to avoid at all costs. The advantages that I want to stress to you of the anterior or the front approach is that it's less invasive. We don't cut any muscles. We go between two muscles. We push them aside. We don't actually cut them. So it's a very easy way to get into the hip. Much faster recovery. I'll show you some videos of people who come back to the office in a week and are not on a cane, not on crutches, not on a walker. People, to me, the biggest thing is people who I've done the older way and the newer way tell me it's night and day. And they, without me even telling them ahead of time, they'll say, what did you do differently? Something is so much better. So to me, that was the real proof. What are the drawbacks? The drawbacks are it's a little more technically demanding procedure. You have to get additional training to do the procedure. You have to do a lot of them. I've been doing this now for nearly 2 years. I've done hundreds of them, and it's much easier than it was, but it still is a more difficult procedure. There's a special table that we have 2 of them at the hospital here, so that's also, I'll go over that with you. So I just want to take you through a typical patient that I see, and some of the pictures may be a little bit more graphic than what you want, but you don't have to look at them for long if you don't want to. So this is a man who's 50 years old. You can see his left hip is what we call bone on bone. There's no space between the two, between the ball and the socket. He's had hip and groin pain now for about 5 years. And that's typical of a lot of patients I see. They've been hurting for years, and people will put up with a lot of pain. They'll try Aleve and ibuprofen and that, but usually after a while that stuff just stops working. So this is that special table that I was telling you about, and it looks like something from the Middle Ages, a torture device, but it's actually a very helpful table, very expensive table that helps us move the hip and work with it automatically, so that it's much easier to accomplish this surgery. And this is somebody actually, this is that man actually on that table, and this is the incision, and this is about a 3 or 4 inch incision in the region of the groin, not kind of off to the side of the groin a little bit. It's in a spot where usually your underwear covers it, so it's not a very hideous incision at all. As I said before, this is a muscle splitting approach. We don't cut any muscle. See these black lines here? This is the area where our body just has a natural space between those 2 muscles, and we can go between those, and we're essentially right in the hip joint. So it's a very easy way to get into the hip, and even on very heavy people, a lot of the fat is in the back, so in the front there really is not a whole lot of fat to get through. So it's extremely easy to get into the hip. So I won't bore you with some of the muscle. This is some of the muscles that we move out of the way, but we move the big muscle called the quadricep. That's the big muscle in the leg. We push that to the side to get into the hip. Again, we don't cut anything. This is an actual picture in the operating room. We wear these these are called space suits, for obvious reasons. They prevent infection, they help the patient, they prevent us from getting contamination. So these are the cleanest barrier between the surgeon and the patient. This is an actual picture inside of the hip. This is, again, some of these are operative pictures. This is the ball of the hip in an actual surgery, where you can see that all of the cartilage is kind of deteriorated off of the ball. We actually cut the ball out. This is the ball cut out on the table. We take it out with a saw and a drill so that we can put the new ball in. Then this is the socket. Can you guys see that? It's kind of dark, but this is the socket. And what we do with the socket is we grind out the socket. We have like cheese grater type devices to grind the socket out to get rid of all the old bone and cartilage to get it back to a nice smooth surface. And that's a tough picture to see, but that's after we what's called ream or grind out the socket. And this is the new socket once it's put in. The outside of it is metal. I have some models up here if you guys want to see them later, but the outside is metal, the inside is plastic. You may have seen on TV or heard in the newspaper about some of the hips that have been recalled are metal on metal. We obviously don't use those anymore. These are ceramic with plastic or metal with plastic, so we don't use any more metal on metal hips. So that's a picture of the new socket. One of the benefits of this procedure that I like as well is that we can have x-ray in the room because the patient's lying on their back. So when we put it in, we can take an x-ray right away to make sure it's in the right position. With the older approach, hip replacement, the x-ray you get is in the recovery room after the surgery. So you're kind of stuck with the position that you've got. So this is nice that you have the x-ray there. If you want to change something, the best time to do it obviously is during surgery. So that's a picture of the x-ray actually in the operating room. These are going to be hard to see, but the next thing we do in the surgery is we put I want to show this here. We actually place a metal stem down into the femur. The femur is the thigh bone. We drill out the femur, and it's going to be hard to see on these pictures, but this is the femur right here. So that is going to be drilled out so that we can pass the stem down into the femur. And that is a picture after that's been done, just like this model, sitting just like that. And then the finished product, if you can see it, that's a pink ball. That's a ceramic. It's a very hard, it's not like the ceramic of china or dishes. It's a very hard metal ceramic and the plastic liner. So that is the new ball and socket joint of the hip. Again, we get an x-ray to confirm the position, and that's done. So to summarize again, it's a muscle splitting approach. There's no muscle cut. The recovery is extremely quick. This is a young lady who is a week after surgery. So with that, I'll be happy to answer any questions you may have. Well, yeah, it's a good point. What I want to stress is that the prosthesis, what we're putting in, is the same whether we go through the front or the back. So the reliability of the prosthesis has to do with several things. It has to do with the brand and the track record, the weight of the patient, the activity of the patient, whether it's put in correctly, it has to be put in the right position. So, you know, most of the hips now we think are about good for 30 plus years. Again, that's dependent on some factors, but just because you have it put in through the front or the back, it's the same components.
What is the brand?
Well, there's many different brands. I use one by Johnson & Johnson, but they're all probably equivalent, the brand.
Is that the only one by Johnson & Johnson?
Because any joints, pain can be referred from one joint to another, so you don't want to get fooled. Some people with knee pain, actually, their pain is coming from their hip and vice versa. So we really want to hone in on the joint that's the most diseased. Sometimes both of them are equally bad. We'll usually do the hip first and then the knee after that. But it's important to find the joint that's actually generating most of the pain. The problem with the knee is it's just it's a more heavily innervated joint. It's just meaning it's more sensitive. It's just a lot of nerve. You know, the reason the gangsters and that use the knee as a target for inflicting pain on somebody is it's probably the most painful joint in our body when it gets damaged. So there's a lot of nerve endings in the knee as compared to the hip. But there's a similar approach that we do in the knee that's fairly widespread now, that where we don't have to cut any muscle. We still have to cut the capsule of the knee, which is the same as the hip capsule. So, but even with that, with quote minimally invasive knee surgery, it is more painful than the hip, and that's just a factor of anatomy of the nerve innervation and how sensitive our knee joints are as compared to the hip. Most people stay overnight. You know, the patients who I've get out the same day are young folks. You know, a lot of these hip arthritis are in people 60, 70, 80 years old. And after somebody's had an operation like this, I don't know that you want to send them out right away. But most people can go home the next day without a problem. So I don't know that's a contest to get people out the quickest. You want to get them out the safest. But the point of that is that there really is not a lot of pain. And for people, like one of the cases I showed, the guy had pain for 5 years. For people who've been suffering with bone-on-bone pain for an extended period of time, the relief that you get, yeah, it's like a groin pull. The groin is sore, but you don't have that bone-on-bone pain anymore. And I've never had it. I just listen to people who tell me over and over it's the worst pain they've ever had in their life. And when they're rid of it, they can't believe it, and they're walking around like they just grinning. It depends on the person. If you've limped for a long time before surgery, a limp can cause some issues with the muscles around the hip. So it takes some rehab, usually 4 to 6 weeks of rehab. Some people I barely need any, but folks who have struggled for a while usually need about 4 to 6 weeks of therapy. The therapy is not all that technically difficult. It's walking, riding a bike, doing some hip strengthening exercises. So it's not anything too technically difficult.